You semua dah ada dah?
Dah ada.
Semua ada dah? Sekejap,
Semua.
saya nak buat air. Sekejap. Sekejap. Start.
Bismillahirrahmanirrahim. Before we start our session, okay. My name is Y5B1 and I will be presenting for the second case-based seminar. So the table of contents for today is: first, child with altered sensorium; second is child with abnormal gait; the third is child who has lower limb weakness; and the fourth is child who has diarrhea. So I will be presenting about the child with altered sensorium. So for definition, sensorium is defined as the state of an individual's consciousness or mental awareness. So the patients are noted to have impaired sensorium if they have mental status changes and or delirium in the context of their current illness. And it can be presented as clouding of consciousness, which include mild form of acute loss of consciousness, Second is confusion, which involves a state of disorientation. The third is lethargy, which describes as severe drowsiness. The fourth one is obtundation, is similar to lethargy but with slow responses to stimulation. The fifth one is stupor, refers to mental state when the patient can only be aroused by repeated and vigorous stimuli, such as pain. And the last one is coma, which is a persistent state of unresponsiveness despite attempts of arousal.
Mula-semula yang ni semula.
Huh?
Apa lethargy. Okay, you all can remember this clouding consciousness, confusions, lethargy. Tapi lethargy ni is bit lethargy just tiredness kadang-kadang very big inilah obstructed betul, stupor, coma. Lethargy ni can be physical weakness, physical tiredness so bit not very clear explanation of lethargy ni. Confusion yes, clouding consciousness yes. You ambil mana ni?
Daripada American College of Surgeons.
Surgeon. Kenapa yang ambil surgeon? Kenapa tak ambil neurology? Patutlah. You tahu tak? Pelik ke you all ni tahu? Your definition tempat pun ambil tak pandai. Kenapa yang ambil neurosurgeon punya American College Surgeon? Sebab tu dia tak lethargy dia. You bila kes macam ni, I beritahu you ambil daripada mana? You ambil daripada medical, neurologi punya ni tau. Kenapa you ambil daripada surgeon? Definition ambil daripada surgeon.
Dapat daripada
CNS, Central Nervous System. Apa kaitan surgeon dengan Central Nervous System? You usually the best is you take for neurology atau ambil of neurology. Daripada you ambil oleh surgeons. You faham tak? Itu tak ada kaitan surgeon pun. At least pun surgical pun tak apa. All ni patutlah dia tak ke dia kita show lethargy tu. Lethargy tu mana ada? Lethargy is physical weakness. It's not included dalam sensorium pun. Kalau you present patient lethargy, immediate dia sensorium. Tahu pun. You people confused tau. Betul pelik. Kita orang tak pernah pakai lethargy as a sensorium punya definition. Lethargy is physical weakness. You quote pun salah tempat. Continue.
So there are 5 except the lethargy one, right? So impaired sensorium is equals to altered mental status, which can be accessed with Glasgow Coma Scale, and equal to decreased level of consciousness. So for decreased level of consciousness could be due to, first is disruption of the ascending reticular activity system, and the second one is most common, which is decreased supply of glucose and oxygen to the brain. And it could be from structural, which is focal pressure in the brain, for example, trauma, brain tumors, and intracranial hemorrhage, and non-structural, such as substrate disruption at the cellular level due to the toxic and metabolic etiologies.
Remember, you all got to go for third year. This is not third year level, Faham? Third year level, yes, you go a lot of the physiology. I dah boleh dalam tu, dalam my instruction dalam tu. Third year, this final year is about the clinical, not physiology. Faham? Baca balik my instruction dalam dalam arah how you write the case ni. I don't know why you want to go about those physiology anymore. Continue.
All right. So for conclusion is altered mental status does not constitute a diagnosis, but it is a symptom of underlying disease that requires a thorough investigation. So these are the differential diagnosis, which are age-based. So we can see there are three participants, which is neonate, toddler, and adolescent. And the most common one is the infection, which is meningitis and sepsis. And the less common is such as cardiac anomalies, and uncommon one is stroke. And next is the different diagnosis based on the etiology. The most common one is the left side, which are the vascular, infection, trauma, and toxins. And the less common one is the metabolic, gastrointestinal, oncologic, psychiatric, and also neurologic. So next is for the clinical assessment. What can we assess from a patient with altered sensorium? First is the patient history. If there is any history of altered mental status, we might have to dig deeper for that, such as if it is acute versus insidious onset, the duration of the symptoms, the family members with the similar symptoms, and if there is any current infectious symptoms and infectious exposures. For the trauma, if there is any relevant accidental versus non-accidental trauma should be considered. However, sometimes history may not be available due to sudden presentation. Next one is the relevant past medical history. If there is any seizure disorder before altered sensorium occurs. Also, if there is any previous traumatic brain injury, cerebral palsy, and also psychiatric history. And the last one is the medication. If the child have possible toxic injections or exposures. Next is the physical examination. For the general, we can look at the appearance of the child. If the child is toxic looking, jaundice, or have rashes, and the head, if it is disproportionately enlarged, if there is any visible dilated veins and bulging fontanelle, any bruises, hemorrhage, or fractures. Next is the eyes, like in the picture. If the patient has sun-setting eyes, which indicates masses in the brain, unreactive or unequal pupils, and papilledema. For breath might be present if the ketone breath, which indicate diabetic ketoacidosis. For the vital signs, we check if the child have febrile or not, and for the heart rate, if it is either tachycardic or bradycardic. For the respiratory rate, if the child is tachypneic or bradypneic, and the blood pressure, if the child have hypotension, which indicates shock, and hypertension, which might be called due to increase in cranial pressure. For the neurological examination, we can do Kernick and Brudzinski sign to check for meningism or meningitis. However, it is a non-specific one. And we can complete the physical examination by doing the Glasgow Coma Scale, the modified version for pre-verbal child, and complete the neurological testing for the age appropriate. The next one is the Glasgow Coma Scale. The pediatrics non-verbal one is modified on the right side. You can see the eye opening like spontaneous to command to pain and none. The verbal response such as age-appropriate vocalization, smile or orientation to sound and interacts such as can follow objects, and also the motor response, spontaneous movements which can obey verbal command, withdraws to touch and withdraws to pain, and so on. So for the scoring, the maximum one is 15. So if the patient have less than 8, it might indicate a severe brain injury, and between 8 and 14 can be moderate to mild brain injury. Next, for the investigations, we can first we can do the capillary blood glucose on the bedside. We can screen for diabetic ketoacidosis or hypoglycemia. For the laboratory workup, we can do for electrolytes to check for any imbalance, and complete blood count if there is any presence of leukocytosis. For the liver function test, if it is elevated in the hepatic failure. For the blood gases, might be hypoxia or hypercarbia, and also metabolic acidosis. For the coagulation studies can show us if there is any hemorrhage, especially in the intracranial. Next is the urine analysis. Can screen for glucose in the urine, and the bacteria or viral cultures, and the rapid antigens if necessary. And then CSF studies such as lumbar puncture, to search for any signs of meningitis, and also serum osmolality. And next one is the toxicology screen. If suspected, like if the patient suspected of ingestion of medication such as acetaminophen, aspirin, lithium, tricyclic antidepressants, and anticonvulsant levels. And if further investigation can be done is the radiographic studies such as CT of the head to evaluate for the evidence of trauma, cerebral edema, bleeding, and CSF shunt malfunction, tumor or mass effect, and may need contrast if suspect of empyema or abscess, and may need confirmatory with MRI. And also we can do abdominal ultrasound to rule out interception. And we can also do electroencephalogram if concerned for the status epilepticus. For the principle of management, first one is the patient presented with acute alteration in mental status. The first line of treatment is to focus on the stabilizing the patient. So the mnemonic is A, B, C, D, E. The first is A, airway. Is the airway clear? And then if there is any blockage, we can do suction or patient positioning and drainage. And the second one is the breathing. We check for the respiration rate and SpO2. If the oxygen is less than 92%, we can do oxygen therapy or assisted ventilation. So for the circulation, we can check for manual pulse and also blood pressure. Can manage with patient positioning. Disability is such as blood sugar. If the patient have hypoglycemia, we can give glucose supplements. And the expose is we perform head-to-toe examination, front and back. We manage any abnormality findings appropriately. And otherwise, these are the management upon dependent upon the etiology of the altered mental status, like airway protection. If the Glasgow Coma Scale is less than 8, we can think of rapid sequence intubation with neuroprotective medications. And the next one is correction of electrolyte abnormalities. We can do glucose infusion or fluid resuscitation. And antibiotics we can give until the cultures become negative for 48 hours. And if the patient presented with seizures, we can give a cessation of seizures drugs such as benzodiazepine or loading with levetiracetam, fosphenytoin, and phenobarbital. And there's also available antidotes if there is any suspected confirmed ingestion of drugs. We can give naloxone for opiates or flumazenil for benzodiazepine. And last one is the neurosurgical consultation. We must immediately treat evidence of increased intracranial pressure. We can maintain the airway protection. We give a mannitol or hypertonic saline solution, and placement of both for external ventricular drain. I think that's all from my part.
Okay, the most important to remember the definition. Go back on the first slide. Go back. This one. So you all must know when you talk about patient confused, you must know what you mean by confused. Clouding consciousness, substandard, stupor, coma. You must know all this. You must know. Because when you talk about the patient, they explain to the phone call, oh, my patient is confused. My patient is stupor. So it means something. It means when you talk to to us as a specialist, or you decide what to do next, this is the one very important. Okay, anything else? Remember, impaired conscious level is a dysfunction of the brain. The conscious level is a function of the brain. So impaired conscious level is dysfunction of the brain. Okay, next. Next presenter.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm Amina Abdulrahman. So I'll present about how to approach a child with abnormal gait. So let's first watch this video. So in this video, we can see a healthy 12-month-old boy walking. If you compare it with the gait of an adult, it looks pretty awkward, doesn't it? But this is considered a normal gait pattern in these ages, which is like 12 plus months. So actually, kids don't develop adult gait and posture until they're around at least 8 years of age. So until this time, there can be like considerable variation in the normal gait pattern. And most of the time, these gait disturbances can be benign, meaning they will outgrow them with the normal development and they don't need treatment. Next. That being said, there are plenty of gait disturbances that have a pathologic origin. Next, please. That have they have a pathologic origin and they need treatment. So the usual way to classify gait disturbances into entologic gait and non-entologic gait. You might have heard of entologic gait before. This is when this is the gait that patients use to compensate for pain. So this is the most common type of gait disturbances. And in this, as you can see in the video, there will be a short stance phase on the affected side. If you remember the normal gait cycle, I didn't include a picture, but in the normal gait cycle, there's like 60% stance phase and 40% is swing phase. And in entologic gait, the stance phase is reduced as to minimize the weight bearing on the painful side. So examples include trauma, any kind of abnormal gait caused by polyarthritis, any kind of arthritis, and then infections and so on. As for non-entologic gait, all the other gaits belong to that. So next, for example, we have circumduction gait. In this kind of gait, which is commonly seen in leg length discrepancies or neurologic conditions like hemiplegic cerebral palsy, the affected leg is the affected leg is circumducted or in other words abducted excessively at the swing phase. And this, the next type of gait pattern, abnormal gait pattern, is spastic gait. We can see this in like diplegic or quadriplegic cerebral palsy or in stroke. In this, there's dragging of the foot, and if you can see, the feet are inversed. Okay, another kind of abnormal gait pattern is the ataxic gait, which we can see in ataxic cerebral palsy and in cerebral ataxia. As you can see in the video, the patient seems like unbalanced, basically, like not coordinated. Okay, so moving on, we have the Trendelenburg gait. And this is caused by, for example, DDH or juvenile idiopathic arthritis and so on. What happens is that there's a downward pelvic tilt towards the unaffected side during the swing phase. Okay. Another gait, which is the equinus gait. This can be normal in children until 3 years old. It's also called the toe walking gait, as you can see in the picture. But when it persists beyond 3 years old, then it can be pathologic. And it's commonly seen in diplegic cerebral palsy. Another common gait disturbance, abnormal gait is the stepping gait, also called the steppage gait. There's lots of other names. In this, the knees and the hips are flexed excessively at the swing phase so that the toes can clear the ground. See if you can see the line over there, both the legs are going to be swung above it. Okay, and the last kind of gait, which is it's called clumsy gait, and it's usually used to describe difficulties in motor coordination, meaning fine and gross motor skills. So children with developmental delay in fine and gross motor domains might exhibit this kind of gait where they'll have like frequent falls and they're just not that balanced. Okay, moving on. So what can abnormal gait be caused by? So as you can see, there are a lot of causes, but like if you think about it, it can be local causes caused by like orthopedic problems, or it can be problems with control caused by neurological causes, and a lot of other systems can affect gait patterns as well. So let's go through the orthopedic causes. Usually we can divide it into traumatic and non-traumatic. For traumatic causes, fractures are the most common cause of abnormal gait. In non-traumatic causes, you can see, for example, developmental dysplasia of the hip, or slipped capital femoral epiphysis, and transient synovitis, which is the diagnosis of exclusion, by the way. All of these are pretty common orthopedic causes of abnormal gait. As for neurological causes, as you might guess, cerebral palsy, and also muscular dystrophy diseases, spina bifida, cerebral ataxia, as we saw, all of them can cause abnormal gait as well. As for infectious causes, septic arthritis and osteomyelitis commonly cause abnormal gait because of the pain. So it's going to be an antalgic gait. And then rheumatological causes as well, such as juvenile idiopathic arthritis. I'm sorry, it's a bit loud in the background. Which causes polyarthritis. So this can cause abnormal gait as well because of the pain and the stiffness. And then we have leukemia as an example of neoplastic causes. Leukemia has bone tenderness and so on. And hemophilia, osteomalacia, and cardiologic causes such as acute rheumatic fever, which also has polyarthritis, which can cause abnormal gait. And not to forget the non-medical causes such as footwear that are ill-fitting, or foreign bodies in like somewhere along the foot, which can also cause abnormal gait. Okay, so moving on to the next, moving on to the HOPI, there are certain important issues that we need to ask. For example, that will help us narrow down differentials. For example, the age. So toddlers, which are like 1 to 3 years old, have different different causes that are common in the age group. For example, transient synovitis and toddler's fracture are the most common causes. And in children, juvenile idiopathic arthritis becomes more common, while in adolescent, the most common cause is slipped femoral epiphysis. And then the onset, like how long it took, several days, or was it like months, weeks, will also help you narrow down the diagnosis. And most important aspect is the pain. Painful abnormalities of gait have different differential diagnosis. So when there's pain, next slide, you'll follow the Socrates method. You'll ask all about the pain. So basically, whether the pain is constant or intermittent, does it come on at rest? Is there like a specific site of pain? Does the pain gradually worsen, or does it radiate? And what is the nature of the pain? All of that can indicate different differential diagnosis, as I've listed down there. So apart from pain at the local, like at the lower limbs, we have to also ask about pain in other parts of the body, such as abdominal pain, and then if there's any associated back pain, and also if there is fever and anorexia, weight loss, night sweats. These are red flag symptoms because they can indicate malignancy or infection that has become severe. Apart from that, so for the other HOPI, you'll have to exclude all of these other histories. For example, history of bleeding disorders that might indicate a hematological cause, history of insect bite because Lyme disease has joint pain as well, history of any preceding diarrhea or infection in general because of reactive arthritis, and then history of trauma, of course. And if it's a sexually active child, then maybe you have to ask about that too, because we have gonococcal arthritis and reactive arthritis, which can cause abnormality as well. Next. So for the other pediatric history, of course, we need to know of any underlying medical illnesses that the child may have, any frequent hospital visits due to injuries, because this is especially if the history and the injuries are not do not tally, because this might indicate child abuse. And then for perinatal history, we have to ask about any prematurity or any delivery complications, which might indicate some kind of developmental delay due to neurological complications. And then, of course, the neuromuscular and other developmental history, family history of any diseases that might be hereditary, or and also social history, which includes the overall level of the child's activity and also if they participate in sports. So you can see how much the gait disturbance affects them in their daily, affects their function. So moving on to the physical examination. Right, so for the general stuff, you need to, in the general examination, you need to make sure to ask, to check, to look for pain, if the child is in pain, any pallor, which might indicate hematological problem or anemia of chronic diseases, any skin changes, such as rashes, which is seen in like several of the rheumatological causes, and also any lymphadenopathy, which might indicate malignancy or infection, any and pay special attention to the feet, if there's any calluses or blisters or maybe even foreign bodies, and so on. As for anthropometric measurements, it's always important in pediatrics, and so here, because poor growth might give you an idea of certain chronic diseases. And then vital signs also, whether they're febrile, are they tachycardic, are they tachypneic, and so on. So the two most like major central examinations in abnormal gait would be the musculoskeletal assessment and the neurological examination. So for the musculoskeletal assessment, you need to assess the child's gait, their arms, legs, and spine. So all the full limbs and the spine as well. So what do you look for? You look for any bone tenderness or soft tissue swelling, any bruising, and also you'll check each of the joints one by one, the symmetry of the appearance, if there's any limitation in the full range of motion of the joints, if there's any muscle wasting, basically the symmetry of the muscles, and also you'll have to measure the limbs, which is using the Galeazzi's test to check for limb length discrepancy. And also one of the special tests is the Trendelenburg's test to check for hip pathology. And then in the neurological examination, again, you have to check for the muscle bulk and symmetry, and also the strength of that is the power of the muscles and the tone and the reflexes. And if there's any persistent primitive reflexes, and also a special test you can do is the Gowers test to test for Duchenne muscular dystrophy. Okay, next slide. So for the investigations, it will mainly be according to clinical judgment, depending on what the child presents with. But in general, we can do several blood tests, such as FBC to look for anemia or leukocytopenia, or we can also do peripheral blood film if we suspect leukemia to look for blast cells, and the inflammatory markers to check for infection, malignancy, or upon all the other arthritis, and also coagulation profile if we suspect coagulation problems, and also the serum calcium and phosphate levels, because they can be high in osteomalacia. Next, there are several specific infectious screening tests that you can do, such as ASOT in case of if you suspect acute rheumatic fever, because it will be elevated, and also blood culture and sensitivity. You'll probably do this anytime a child presents with fever. And bone culture if you suspect osteomyelitis, and also if you suspect septic arthritis, then you'll have to do joint aspiration and synovial fluid culture. And in the cases of SLE, we'll have to send for the antibodies, NA and the double-strand DNA, and also for the serum muscle enzymes such as CK, ALT, and LDH, which will be increased in inflammatory muscle diseases. And imaging, X-ray is usually a must, for example, to rule out fractures or any other soft tissue problems. And then in cases of where you might suspect joint effusion, we can do ultrasound. Okay, next. So management is also general, depending on how the patient presents. But basically, you can divide it into pharmacologic and non-pharmacologic as usual. Pharmacologic will include antibiotics if there is infection. Usually, for example, for septic arthritis, depending on the age, you'll give some generation of cephalosporins. Or you can give like penicillin type antibiotics as well. And then for inflammatory joint pain, such as seen in like rheumatological diseases, you can give NSAIDs or intra-articular steroid injections, or disease-modifying anti-rheumatic drugs if they don't respond to any of the others. In spastic limb conditions, we can give antispasticity medications and botulinum toxin injections. For non-pharmacological management, this will include physiotherapy to improve the range of motion of the muscles and to strengthen them, and also occupational therapy to help with to train the child in activities of daily living with the abnormal gait. And also it might include special equipment. This will be like under the orthopedic thing, like equipment like walkers or braces or some kind of walking aid. As for surgery, it can rarely be needed. Usually it will be orthopedic surgery such as muscle or tendon lengthening for like CTEV, or osteotomy if there's like a severe limb length discrepancy and so on. And of course, not to forget, you have to treat any underlying medical condition which may affect the gait pattern of the child. Next, yeah, so that's all from me. Thank you. Next.
Okay, you see, during my time, last time, we had to wait until the patient around, then only we can observe the gait. But you all, your time, you all can see the gait, study the gait using the internet. So there's no reason to know the gait anymore. Last time we had to wait. We had to wait patient admitted to the ward, then we can only study the gait. So we don't have this kind of advanced technology. So make full use of it. Okay, next.
Bismillahirrahmanirrahim. Assalamualaikum and good morning everyone. So my name is Sharifah Hajar binti Said Jamaluddin. I will proceed the presentation.
Next presenter.
Tak dengar.
Dengar. I don't know.
Dengar. So I'll proceed the presentation with a complaint child who has lower limb weakness. Okay, so for introduction, we must understand the terminology first. Weakness is this decreased ability to voluntarily and actively move muscle. Weakness also can be used other term as paresis or paralysis. And then the other term is hypotonia. It is different. Hypotonia is low muscle resistance to movement. Okay, so this weakness, it can happen, it can arise from any lesion in upper motor neuron or lower motor neuron, neuromuscular junction, skeletal muscle, or systemic disease. As you can see in the picture, the upper motor neuron transmit information from the brain to the spinal cord, and lower motor neuron from the spinal cord, it leaves spinal cord and then go to the anterior horn cell, and then peripheral nerve and muscles. Okay. Hypotonia also can associate with weakness, but in some cases, it present with normal motor strength. Next. Okay. As I said before, it can happen at any part, lesion of any part of our body. So causes of lower limb weakness, we can divide it into upper and also lower motor. So for upper, brain and spinal cord. So I just say the most common because there's so much disease here. So
Dah, you
for
rajin sekali letak semua. Tak apalah. You letak semua kena, tak apa, letaklah semua. Tapi you kena tahu mana common Okay,
Okay. So among the common acute transverse myelitis from spinal cord, it is acute inflammation of spinal cord with motor and sensory deficit. And then poliomyelitis, it is not in Malaysia anymore, but it can happen. So it compromises the anterior horn of spinal cord, secondary to polio infection. And then GBS, Guillain-Barré syndrome, acute autoimmune mediated polyradiculoneuropathy, spinal muscular atrophy, autosomal recessive condition that characterized by weakness and skeletal muscle atrophy. It can diagnose in a floppy infant instead of older children. And then myasthenia gravis, neuromuscular disorder that caused by blockade of acetylcholine receptor by specific antibody that prevent the muscle contraction. And then tip paralysis, the neurotoxin that causes the ascending weakness, botulism, toxin from botulinum, and then myositis can occur in systemic viral or bacterial infection, and then Duchenne muscular dystrophy, autosomal dominant condition that caused by that characterized by progressive muscle degeneration and weakness due to alteration of protein that called dystrophin. Okay, next. So this is one of the most common. So I think you can read it by yourself. But Guillain-Barré syndrome, I can say it is short-term but life-threatening condition because it demyelinating disease. So okay, and then one of the most common classic characteristic, it is ascending weakness. So it usually start from lower limb. Okay, next. Okay, moving on to a history of presenting illness. So first and foremost, we need to ask regarding the lower limb weakness. So for the onset and progression, in myasthenia gravis, the onset and progression of weakness usually slower. And then we need to ask symmetrical or asymmetrical, because in poliomyelitis, it is asymmetric. And then location of weakness at onset, is it proximal or distal or generalized? Okay, if generalized, it usually metabolic myopathy, and then ascending or descending, progression and severity, previous episodes of weakness, it worsening or relieving factor, and then associated symptom, and also history of preceding infection of a periphase. And then we need to ask bladder or bowel function, and then back pain, bulbar involvement, facial paralysis, oculomotor involvement, is it involve the cranial nerve, and then respiratory failure, respiratory distress symptoms such as difficulty in breathing or cyanosis. Okay, so usually for disease of peripheral nerve, it usually affect the distal muscle first. Okay, and then for spinal cord lesion, usually more likely to associated with early sphincter dysfunction. Okay, next. So for other history, we need to ask regarding ingestion of toxin or toxin substance to rule out toxic myopathy. and the ingestion of spoiled preserved canned food to rule out botulism, and then immunization to rule out poliomyelitis, and family history, is there any autoimmune disease, hereditary neuromuscular disease, and birth history, preterm delivery, maternal infection. And for birth history, we need to ask detail regarding the pregnancy, the delivery, and postnatal period, because infection can cause can come from due to the preterm delivery. Is there any infection during the during birth? And then it's like lactose infection. Okay, and then for developmental history, need to ask regarding the delayed motor milestone, speech, to exclude brain pathology. And for motor delay with normal social and language development, usually decrease the likelihood of brain pathology. And if the children has loss of milestone, it increase the suspicion of neurodegenerative disorder. Okay, next. Moving on to physical examination. So we look the patient as general first. Is he or she alert and conscious? Respiratory in respiratory distress, and look for any syndromic phases. And then for surrounding, wheelchair or using walking stick. And then for central nervous system, first inspect the muscle bulk. Is there any muscle wasting, like pseudo hypertrophy that you can see in the picture? Duffy field. And then is there any presence of engorged tick paralysis? Any fasciculation that suggests low motor neuron lesion? And then check for lower limb examination for motor. Is it hypo, normal, or hypotonia? Power, reflex, Babinski reflex. And then sensory. And then check for cranial nerve examination. Ptosis, facial weakness, complete eye movement, gait, like I mentioned before. And then check for meningeal sign, cerebellar exam, and also anal tone. Okay, for tick paralysis, to look out for tick, watch out for tick neurotoxin, and then meningeal sign to exclude pseudoencephalopathy, and patient that have reduced sensation usually in Guillain-Barré syndrome and also acute transverse myelitis. And then other system, we need to check like respiratory system if patient is in respiratory failure. Next. So this is Gower sign in Duchenne muscular dystrophy. The patient usually arises from lying on floor by using arm and then climb up on the leg and body. And this is due to the proximal weakness. Then the meningeal signs. Okay, next. Okay, this is to summarize. You need to differentiate between upper motor neuron and also lower motor neuron based on the physical examination. Next. Okay, for investigation, we can do a full blood count to rule out underlying infection. And then serum creatinine kinase, it is elevated in inflammatory myopathy, such as viral myositis, polymyositis, and Duchenne muscular dystrophy. Then we can check for serum electrolyte to exclude metabolic myopathy, like hypokalemia, hypocalcemia. Then we can do lumbar puncture to rule out infectious process. And then nerve conduction study. This is essential in neuropathy and neuromuscular junction problem. Then electromyography, like in the picture. You can see abnormal muscle response to repetitive nerve stimulation in neuromuscular junction disorder such as myasthenia gravis and also botulism. And then we can also do MRI spine with contrast to rule out spine pathology. So as you can see here, investigation we do specific for what we suspect. Okay, next. Okay, moving on to the management. This also just general. I mean, this is also depend on what the disease give. So first, for general management, we need to assess the stabilization of airway, breathing and circulation, also vital sign, because usually patient that come with acute weakness, acute weakness is really life-threatening. Okay, and then so for principle of management, for brain tumor, we need to refer neurosurgical team. Infection, we need to treat with antibiotics. And then transverse myelitis, we can give high dose steroid. Guillain-Barré syndrome, we give IV immunoglobulin with plasmapheresis and immunosuppressive drugs. And then myasthenia gravis, we can give cholinesterase inhibitor. And then Duchenne muscular dystrophy, chronic oral steroid therapy, and supportive care. For tick paralysis, we need to remove the tick. And poliomyositis, dermatomyositis, can give corticosteroid and immunosuppressant for 6 to 12 months or longer. Then for botulism, need to give supportive care. And then because antibiotic can destroy the Clostridium membrane, and we need to avoid because it may release the toxin. Okay, next. Okay, last one. This is important to rule out for acute flaccid paralysis because Malaysia is remain a polio-free country. So if we have all these sign and symptom, we need to report because it highly suspicious of poliovirus infection. So acute flaccid paralysis, usually rapid onset of motor weakness, and it can also have weakness of respiration and swallowing, progressing to maximum severity within these 2 weeks. Okay, so this is the macam flow chart. Okay. All right, next. I think that's all from me. Thank you.
Okay. Next presenter. The weakness tu, you have to decide apa volume, 2 volume lah, tapi it's okay, discussions okay lah.
Assalamualaikum dan salam hormat
Sekejap.
kepada seluruh perkitangan dan warga kerja Sultan Ahmad Shah Medical Center IUM. Adalah dimaklumkan penjualan pelekat kenderaan Sasmed IUM bagi sesi 2023-2024 kepada para perkitangan dan warga kerja hospital boleh dibuat di kaunter Jabatan Kewangan Alas 2 Sasmed IUM. Para kakitangan dan warga kerja Sultan Ahmad Shah Medical Center IUM adalah disarankan untuk membuat permohonan mengikut jadual yang telah ditetapkan bermula 13 hingga 23 Disember 2022. Sila rujuk pautan email untuk maklumat lanjut yang berkaitan. Saya ulangi, para kakitangan dan warga kerja Sultan Ahmad Shah Medical Center IUM adalah disarankan untuk membuat permohonan mengikut jadual yang telah ditetapkan bermula 13 hingga 23 Disember 2022. Sila rujuk pautan email untuk maklumat lanjut yang berkaitan. Kaki tangan adalah diwajibkan untuk mempamerkan pelekat pada kenderaan masing-masing. Kegagalan mempamerkan pelekat kenderaan yang sah akan dikenakan tindakan compound, saman, berkuat kuasa serta merta. Mesej ini dibawakan khas oleh Unit Pengurusan Keselamatan Sasmed IUM. Sekian, terima kasih.
Okay, Assalamualaikum. I am Aida Sabrina and I will be presenting regarding child who has diarrhea. Next. So first of all, we have to know the definition of diarrhea. So WHO says that diarrhea is the passage of 3 or more loose or watery stools per day or more frequent passage than is normal for the individual. So diarrhea can be categorized into acute or chronic according to the length of the duration. So for acute diarrhea, it is the abrupt onset of 3 or more loose stools per day and it lasts for less than 14 days. While for chronic diarrhea, it is the episode of diarrhea that begins acutely and lasts for 14 or more days. Okay, next. So this is among the most common differential diagnosis of diarrhea. So we can classify into acute and chronic and according to the age group. So for infants, the most common one for acute diarrhea is viral gastroenteritis, such as rotavirus. Next, it is followed by bacterial gastroenteritis, such as Shigella or Salmonella, and then protozoa. And then systemic infection, antibiotic-associated, and overfeeding can also cause acute diarrhea in infants. Meanwhile, for chronic diarrhea, it can be due to calcium protein allergy, chronic non-specific diarrhea of infancy, or also known as toddler's diarrhea, post-enteritis syndrome, and excessive fruit juice ingestion. Meanwhile, for child, it is the viral gastroenteritis is also most common one, followed by food poisoning, systemic infection, and antibiotic associated, while the chronic diarrhea can be due to lactose intolerance, post-enteritis syndrome, irritable bowel syndrome, inflammatory bowel disease, and giardiasis. Okay, next slide. So for the history, we'll go to the acute diarrhea first. So when a patient comes to us with acute diarrhea, so we must inquire regarding the diarrhea itself. When is the onset? When did it occur? Is it after ingesting some spoiled food? Because it could mean that it is due to food poisoning, or is it after drinking milk? Because it could be due to lactose intolerance. And what is the number of episodes per day, and how much is the amount of the diarrhea? Because we would like to quantify the hydration level of the patient. And then we should also ask regarding the presence of blood or mucus, such as in Shigella or Salmonella infection. And then we should also ask regarding the normal bowel habit for the child. And is this and if this is the first episode of the occurrence, because we would like to know if this is really acute. Okay, and then we should also ask regarding any recent history of eating outside food, because it could show that this could be AGE, or any recent change of formula milk, any sick contact, anyone with the same symptoms, such as in food poisoning, for example, any recent traveling, because it could be due to infectious diarrhea like giardiasis, which is the traveler's diarrhea. Okay, and then we should also ask regarding the associated symptoms, such as vomiting. So if the patient has vomiting, what is the content? Is there any blood? What is the amount? What are the number of episodes? So next, we should also ask regarding the oral intake, if there is any reduced oral intake. So what is the normal food intake before the illness and currently during the illness? Because we would like to know regarding the hydration status of the patient, which is very important. So we can ask the guardian if the child looks less active, has sunken eyes, has dry lips, looks thirsty, and has decreased urine output, because it is important for us to guide us during the management later on. Okay, we should also ask regarding fever, is it a low grade or high grade? Because high grade fever could show that this could be due to bacterial infection. Any recent antibiotic history, because antibiotic can cause diarrhea as well. And then if the child is from dengue prone area or if there is any rodent infestation or pets at home, because dengue and leptospirosis can also come with fever and diarrhea as well. And then we should also ask regarding abdominal distension, if there is any increased fluidus or abdominal pain, especially after drinking milk, because it could show that this could be due to lactose intolerance. So any rashes or weight loss. Next. Next slide. Okay, so other pediatric history that we should inquire during the history taking is the past medical history, if the child is immunocompromised, any recent medications, any use of laxative or any use of antibiotics, any allergy. And then we should also ask regarding if the child has any additional vaccines, such as rotavirus, because it could be protective against rotavirus causing acute gastroenteritis. And then we should also ask regarding nutritional history, the normal diet intake, if there is any large amount of formula milk or fruit juice taken. And we should also ask the parents regarding milk bottle hygiene. And then we should also ask anyone with the same complaint. And for social history, as regarding the water sources, because it could be due to infective diarrhea like E. coli, Giardia lambiasis, and so on. Next. Okay, so for physical examination, our aim is to assess the hydration level of the patient because this is acute. So generally, we should see the patient and classify it into whether the patient is mild, moderate, or severe dehydration. So we can see if the child is well and alert, has no sunken eyes, drink normally, and the skin when being pitched is goes back immediately. So it could be it is mild dehydration. If we see that the child could be restless or irritable, has sunken eyes, drink eagerly or thirsty when we offer them water, and the skin goes back slowly. Any two of these aspects could show that this is moderate dehydration. And for severe dehydration, the child would appear lethargic or unconscious, has sunken eyes, will drink poorly or do not want to drink at all, and the skin will go back very slowly, which is more than 2 seconds. So for the vital signs, we should see if there is any signs of severe dehydration or shock, like weak pulses, tachycardia, tachypnea, normal hypotension, and also see the temperature of the child if the child is febrile or afebrile. And then for abdominal examination, check for any tenderness, any distension, as well check for the perianal examination if there is any excoriation or any rashes. Okay, next. So this is the picture of a severely dehydrated child. So from the top to the bottom, the child would have sunken fontanelle, eye sunken and tearless, reduced level of consciousness, dry mucous membrane, reduced capillary refill time, and then tachycardia, tachypnea, hypotension, peripheral vasoconstriction, reduced tissue turgor, sudden weight loss, and oliguria. Okay, next. So this is the summary of what I have presented just now. The mild dehydration, moderate dehydration, and severe dehydration. Okay, next. So going to the chronic diarrhea. So if a child presents to us with diarrhea that is 14 or more than 14 days, then we should ask regarding the onset. When is the onset? Is it congenital? Because there could be any presence of sodium malabsorption in the patient. Is it abrupt? Because it could be due to infection. Is it gradual or with the introduction of food? Because it could be due to celiac disease. And then we should also ask regarding the characteristic of the stool. Is there any blood? Because it could show that could be due to IBD, or is it light or tan color? Could be due to celiac disease. Again, we should ask regarding the associated symptoms such as abdominal pain, flatulence, and loss of weight or failure to thrive, because such as in malabsorption or pancreatic exocrine insufficiency. So in chronic diarrhea, the most common complication is malnutrition. So we should ask regarding that. So if the child has looks lethargy, irritable, has dry skin, has brittle hair, and has frequent infections. And we should also inquire regarding the patient's hydration status as well. Any sunken eyes, any dry lips. Does this child look thirsty or reduce urine output? And then we should also ask regarding the past medical history, any IBD or immunocompromised child, and the past therapeutic interventions such as drug side effects, because prolonged usage of antibiotic can also lead to diarrhea as well, and then radiation enteritis. Okay, and then as regarding any family history, and for the social history, any what is the water supply, how is it clean or not, and the hygiene of the patient. Next. So for physical examination in chronic diarrhea, as I said before, the most common complication for chronic diarrhea is malnutrition. So we should see the evidence of malnutrition in the patient. Does the patient has severe muscle wasting, like you can see in their picture, marasmus. So we can check the muscle bulk by measuring the mid-arm circumference. We can also check the subcutaneous fat by measuring the triceps skin fold thickness. Again, we should see the hydration status of the patient and see the evidence of nutritional deficiency And then we should also see if there is any extraintestinal signs of IBD, such as oral lesion, uveitis, episcleritis, erythema nodosum, and pyoderma gangrenosum. Next, the most important one is anthropometric chart, which is the growth chart, because the complication of chronic diarrhea is malnutrition. So we should see if the child has failure to thrive, and then look at the vital signs if there is any tachycardia, tachypnea, hypotension, and fever, because it could show that the child is severely dehydrated or not. And then also check the abdomen for any distension, tenderness, and bowel mass. Okay, next. So this is the extraintestinal sign for IBD. The upper one is the episcleritis, bottom one is pyoderma gangrenosum, and the right one is oral lesion. Okay, next. So for investigation, it depends on our differential diagnosis, but we can classify into blood investigation, stool investigation, and imaging investigation. So for blood investigation, we could do a full blood count to see if there is any anemia, especially in chronic diarrhea, anemia of chronic disease, folate deficiency, and then look for any leukocytosis that could show infection and thrombocytosis. And then for renal profile, in dehydrated patient, the urea and creatinine will be high. And then for liver function tests, we should see if there is any hypoalbuminemia in malnutrition patient. And then for ESR and CRP, it will be raised in any inflammation. And then if we suspect the patient is having shock, then we do ABG to see if there is any metabolic acidosis. And then if the patient has poor oral intake, then we can do random blood sugar to check for hypoglycemia. Okay, next, for stool investigation, we could do stool full examination, microscopic examination to see the presence of blood and leukocytes, such as in Shigella, Salmonella, or E. coli infection. And then we can also check for stool pH, electrolyte content, and osmolarity to differentiate between the osmotic and secretory diarrhea. And then we can also send for stool culture and sensitivity to rule out any infective etiology, such as stool for rotavirus causing AGE, stool for ova and cyst for any parasites, and Clostridium difficile. And then we can also send for fecal calprotectin if we suspect the patient is having IBD, and it will be raised. Okay, next. For investigation, for imaging, we can do contrast studies such as in upper GI barren contrast to study the gross anatomy of the upper GI tract. So we may find any congenital malformation or motility disorder. And then we can also do CT scan of abdomen or MRI to see any small bowel involvement or stretching in the IBD. And then for the other investigation, we can do colonoscopy and biopsy for histology and culture to look for the areas that involve in IBD and obtain tissue for biopsy of diagnosis. Okay, next. So for the management of diarrhea, we go to acute diarrhea first. So it depends on the hydration level of the patient. So if the patient is mildly dehydrated, we can give plan A, which is to give fluid and food to treat diarrhea at home. Or if the patient is moderately dehydrated, which is the patient is irritable, restless, has sunken eyes, drink eagerly, and skin goes back slowly, then we can give plan B, which is to give fluid and food for some dehydration. And if the child is severely dehydrated, in which the child could have lethargy or unconscious, has sunken eyes, drink poorly or not being able to drink, and the skin go back very slowly, we give plan C, which is to give the IV fluid for severe dehydration. And we should provide food as soon as the child tolerates. So in general, the principle of management for acute diarrhea is to give fluid to replenish the fluid loss. So we should advise the mother to breastfeed the child frequently and longer, to give fluid-based food like soup, and then give oral hydration solution. And if the child is severely dehydrated, we can give IV fluid therapy. And then we can also advise the mother to continue feeding and know when to return to the hospital, especially which is when the child drink poorly or not being able to drink or breastfeed. If the child becomes sicker, develop fever, and has blood in the stool, then the mother or the caretaker should bring the child to the hospital. And then for pharmacological agent that can be used for the management of acute diarrhea is antimicrobial in cases of bloody diarrhea or in cases that we think that bacteria is the cause, and then zinc supplement. Okay, next. So the principle of management for chronic diarrhea is we resuscitate the patient with IV fluid. We correct any fluid or electrolyte abnormalities, hypoglycemia, and prevent hypothermia. And we should also identify and treat the underlying causes of chronic diarrhea. And then we can do nutritional assessment and rehabilitation. For example, in child with micronutrient deficiency, so we can give micronutrient supplementation. And then for child with lactose intolerance, we can advise the mother to continue breastfeeding and give the child lactose-free formula milk. And then we should also do serial monitoring of serum electrolyte in early stages of nutrition and recovery. That is all from me.
Okay. Any questions? Any questions? Tak ada? Okay, I only for long leave, so the Taufik will take over for me for a while. I'm coming back to take exam, so jumpa masa exam. And the posting exam. So good luck for you all. Okay. Okay lah. Ada apa lagi? Tak ada apa lagi? No question kan? You all dah know everything kan? Okay. See you all exam nanti. Dia tahu exam siapa yang pergi overseas tu Siapa yang pergi overseas tu?
Saya.
You pergi mana?
Korea.
Korea?
Ya.
Allah, ingat tadi pergi ke Europe ke mana? Korea, tiket dah beli dah?
Beli belum tahu exam.
Dah
beli dah. Belum tahu
You dah beli tiket belum?
Dah.
You nanti you bincang dengan tu Dr. Alwi dah beritahu dah?
Dah beritahu dah. Exam.
Okay Okay, finish. Good luck. Okay
Thank you, doctor.
Okay
Thank you, Doctor.
Thank you, Doctor.